Did you know that Incident 2 billing is on the Office of Inspector General's work plan this year for 2013? Well, that's why today we're going to discuss the ins and outs of Incident 2 billing. I'm Jackie Thelian, and these are your key coding tips. Incident 2 services are not identified on any claims data. That's why they're subject to review. Let's take a look at what you need to know to be compliant. Understanding Incident 2 services. What are Incident 2 services? Well, simply stated, it's when one qualified individual provides a service that's supervised and billed by a different qualified individual. So statistically, we see that a lot of these Incident 2 services are provided by nurse practitioners and physician assistants. But there are certainly other types of qualified individuals who also can provide these Incident 2 services, such as a clinical psychologist, or maybe even your medical assistants or an RN. The rendering provider must have sufficient training or qualifications to provide the services. And these services may be provided in an Incident 2 type of setting once that physician has performed the initial service. So there first needs to be an interaction or an encounter with the physician before the additional service can be provided incident to that service. The patient would need to be an established patient, and most importantly with an established diagnosis. And we're going to talk about that in detail in just a minute or so. The physician does not need to see every patient visit, but they must prescribe the plan of care and actively manage it. And the physician must have a face-to-face encounter with that patient prior to the service being billed Incident 2. So these require direct supervision. And direct supervision is defined as the supervising physician must be present in the same office suite and immediately available during the encounter to furnish assistance and direction when necessary. So the physician does not need to be in the same room with that provider while the service is being done, but they do need to be immediately available, and they need to be in the office suite. Now, I know that there's a myth out there, or how this got started, I don't know, but a lot of providers are under the impression that Incident 2 supervision requires only that physician, that supervising physician, is available by telephone. And for documentation and billing purposes, that is not true. So again, one of the key points you need to focus in is that the direct supervision requires that that supervising provider is in that office suite and available to provide assistance. Now, direct supervision rules also apply for any other allowable place of service outside the office where Incident 2 services are allowed, such as place of service 12, which is the home. So if you use or utilize your nurse practitioners and your physician assistants to go out and do home visits, the only way those can be billed Incident 2 is if you were there with them providing direct supervision. Now let me make this clear. It doesn't mean that the service cannot be provided. That service can definitely be provided. It just means that that particular service would have to be billed out under the nurse practitioner or the PA or whomever is providing that service, and you would get the reduced fee schedule rate. So another thing to note about the supervising physician, it does not have to be the physician who performed that initial visit, and it does not have to be the patient's primary care physician. So it would be any qualified physician that's within that same group who's in the office suite that day while that service is taking place and immediately available to provide assistance if necessary. Now, where can these Incident 2 services take place? Well, typically they happen in the physician's office. They are not allowable in a hospital setting or a skilled nursing facility. And this is another key tip, because this is where a lot of providers go wrong. So once again, if you're sending your nurse practitioners or your PAs over to do your hospital rounds or to see the patients in the hospital, they can definitely be billed under that PA or a nurse practitioner, but they cannot be billed incident to because of the place setting. If furnished in an outside setting, outside of the office, such as a home, as we discussed before, there must be direct supervision. And again, to reiterate, phone contact with the physician does not constitute or meet the criteria of direct supervision. So some things to know. We now know what incident to services are. Let's figure out what they're not. It's not a visit by an established patient for a new problem. Again, key point. So if the physician, the supervising physician, sees the patient for the first time, and then the patient comes and they're going to be followed up with the nurse practitioner or the PA for that same problem for which that supervising physician is managing, that's fine. But if the patient is now presenting and they have a new problem, that new problem needs to be evaluated by that supervising physician. They need to determine the treatment plan, and they need to provide that type of guidance before this can be billed incident to. So a visit by an established patient for a new problem basically needs to be seen by that supervising physician. The service of scribes is not to be confused with incident to. A scribe is someone who's documenting the note for you, and there are special attestations that need to be included in the medical record in order to utilize a scribe. And another key point, incident to is not from physician to physician. So early on in the PowerPoint, we give you a list of those who can provide those incident to services. And you'll notice that MDs, DOs, physicians are not included on that list. And there's a very good reason why. Because the services of an MD cannot be billed incident to another MD. So if I were to hire a new provider into my practice, and he's not credentialed with some of those insurance companies, I cannot bill his services under me until he or she becomes credentialed. And that's a very valid point, and this is another area where a lot of providers make this mistake. While the co-signature of the supervising physician is not required for incident to, the documentation should have evidence that that supervising physician was actively involved in the care of the patient and present and available during the visit. So, you know, we do intend, or the rules tell us that at some point the supervising physician is still actively involved in care for the patient. Although the guidelines don't tell us that every third visit or every fourth visit this is required, they do want to see documentation within the patient's record that that supervising physician is still maintaining active participation in the care of that patient. We don't want to confuse this co-signature with the PATH rules, which is a whole different set of rules and regulations for physicians at teaching hospitals. And in those regards, that's where that co-signature is required. So to sum this up, we can bill under the physician's PIN when the service is shared between the physician and the nurse practitioner, meaning that both are actively involved and are participating in that patient's care. When the patient is established, meaning that there already was an initial incident or encounter in which the physician saw the patient. And in those cases, incident to criteria would be met, and we would get 100% of the Medicare physician fee schedule. If the incident to criteria is not met, again, those services would be billed out under that nurse practitioner or that PA, and you would receive the reduced fee schedule for those services. In the hospital, inpatient, outpatient, or ED setting, You can bill it under the physician's PIN when the service is shared between the physician and the nurse practitioner or PA for the same group, and that is a split shared visit. And they have their own certain rules and regs that need to be addressed before one can bill a split shared visit. And that's where the physician would need to provide face-to-face portion of that encounter on the same day that that PA or NP saw the patient. In those cases, they would be billed as a split shared visit and would get 100% of the Medicare fee schedule. When there is no face-to-face encounter between the physician and the patient, you would then bill that under the nurse practitioner or PA. There are certainly many places that you can go to learn more about this. And I always say go to the source. The source in this case is the Centers for Medicare and Medicaid Services. They provide excellent information, and it's absolutely free. So on your PowerPoint, I give you references, whether it's in the internet-only manual from CMS, and also worth checking out is MedLearn. So if you just Google MedLearn, you should sign up for that. It takes a lot of these complex rules and regulations. It puts them into simple English so that the providers can understand it, and you can sign up for this and get free updates. Of course, you can always go to the Office of Inspector General, the OIG's website, and there you can download the 2013 work plan, and you'll see specifically what they're looking for when they come to audit these Incident to services. Well, I hope you found this information helpful. Thank you.